living with HIV, experiencing homelessness, and under and unemployment. My name is Shatara Johnson. I will be your moderator today. I'm also a member of the PASWA board as well. I would like to just let you know that presenters will have 60 minutes to present and 15 minutes for question and answer. Please submit your questions for the speaker via the chat box. Questions will be answered at various points during the session. At this time, I would like to introduce your speakers. First, Jamie Shank, Quality and Housing Manager of the City of Kansas, Missouri Health Department, Kansas City, Missouri. Eric Moore, MSW, HRSA Homes Program Manager, Positive Impact Health Centers, Decatur, Georgia. Julia Doherty, Licensed Clinical Social Worker, Program Manager of Boston University. Speakers, you now have control of your presentation.
Thanks so much, Shatira. I know we gave you the longest possible title of a presentation to read off, so thanks. We're really excited to have everyone here today. And our learning objectives for today's presentation are to identify the challenges for people with HIV, including long-term survivors and an aging HIV population with maintaining stable housing and income, describing the role of social workers as a part of an interdisciplinary team to address housing and employment needs for people with HIV, learning to set up systems to make and complete referrals and share information across health, housing, and employment programs. So I'm going to start off with just a little bit of the study background with the information that we'll be presenting today from the HIV Housing and Employment Project. So we're currently in the final year of a 3-year demonstration project cycle, and it's funded through the Department of Health and Human Services, Secretary Minority AIDS Initiative Fund, and the HRSA HIV/AIDS Bureau Special Projects of National Significance Program. There are 12 demonstration sites funded to improve health outcomes for low-income, uninsured, and underinsured people living with HIV and ethnic and racial ethnic minority communities by coordinating health, housing, and employment service systems designed to address social determinants of health. So there's 12 demonstration sites working on those outcomes and 1 evaluation and technical assistance center, which is working to coordinate the evaluation, technical assistance, and dissemination. So these are our sites around the US, and they reflect many different settings, ranging from Ryan White Health Centers, city health departments, federally qualified health centers, and aid service organizations. So our key outcome questions for the initiative are, does the intervention increase retention and quality HIV care, increase viral load suppression, improve housing stability, and improve employment status? But we also want to know how it works and how it was to implement. So what are the strategies that work best for expanding employment opportunities for homeless and unstably housed people living with HIV? What is the level of engagement needed to get a person living with HIV employed? What are some of the barriers to implementing projects? And how can this be integrated into existing site work? So we use this theoretical model, which is Mittler's model of client engagement transposed over an ecological model. You can see in the center, there's individual characteristics around activation and engagement in care. Using this theoretical framework, we will be able to understand how social determinants of health impact HIV care and viral suppression. So it shows us the key elements that we collect as part of our evaluation to understand consumer engagement and housing and employment services, and the impact of engagement on healthcare, and then ultimately viral suppression. So a little baseline data about the clients who were enrolled in the study and their demographics. Folks who were enrolled needed to be 18 years or older, HIV positive, and meeting one of the following criteria: either newly diagnosed within 12 months, not engaged in HIV primary care, at risk of falling out of care, which includes clients who are re-entering, re-engaging from incarceration, and then those who are not virally suppressed. They also needed to be homeless or unstably housed, which means literally homeless or at risk of homelessness, fleeing domestic violence, or in permanent housing but received a shut-off notice within the last 60 days, or other things that put them at risk in the category of unstable housing. And then underemployed or unemployed. So in the underemployed category, that is anyone who is employed part-time but would like to be employed full-time, is receiving SSI or SDI but demonstrated an interest in additional income up until the threshold that would allow them to maintain their benefits, or was working but was not making enough to achieve their basic needs. So using this eligibility criteria, we enrolled 1,083 clients into the study across the 12 sites. So a little bit of baseline information about who these clients were. 77.7% of clients identified as a cisgender man, 17% cisgender woman, and about 4% identified as transgender, with 3.3% identifying as a transgender woman. And we had a very large age range in this project, which required sites to work across the life course. You'll note it was 18 to 73 years of age, and we're interested in looking more into housing and employment status and experiences in the intervention based on age and long-term survivorship status. For race and ethnicity, it's important to note that this was a check all that apply response, so the percentages may equal more than 100, but about 43% identified as Black or African American, about 33% Hispanic, about 13% white, and around 83% were US born. The highest level of education achieved at baseline for the majority was beyond high school. And then we asked for self-reported HIV medication adherence at enrollment, and we can see here over half of the clients self-reported that medication adherence was very good or excellent. And given the eligibility criteria, as at risk of falling out of care, this highlights impacts of access and social determinants of health and affecting medication adherence behavior. So for example, without transitional care coordination, folks exiting incarceration, I'm seeing like drawings on my slides. I'm not sure where they're coming from. Sorry about that. Folks who are currently reporting exiting incarceration, who are currently reporting very good or excellent adherence, may run out of medication if they don't have transitional care coordination, which would impact med adherence and ultimately viral care. So we also wanted to look at incarceration history, and you can see there's a notable portion of the study population having experiences with the criminal justice system. And this is an example of the need for interdisciplinary partnerships to ensure that clients had the support and resources they needed for re-entry, and that providers were educated on legal concerns of clients or knew a partner that they could be referred to help with these needs. Additionally, according to client responses and baseline surveys, 70% were at risk of depression, and based on the general anxiety disorder scale, 53% had moderate to severe anxiety. We also looked at substance use in the past 3 months, and in thinking about these responses, it's important to note that there's a high percentage of folks who declined or decide not to report their usage, but we can see that about 48% reported they've used cannabis in the past 3 months. About 15% reported they used cocaine, and about a quarter reported amphetamine use. So these last two slides speak to the need to address mental and behavioral health needs as part of achieving housing and employment. And at baseline, about similar percentages reported being homeless or unstably housed, so around 43% each, and 86% of clients were ever homeless. So this points to the difficulties in maintaining stable housing, especially those who are under or unemployed. And for employment status, about 80% were not currently working at enrollment, and 19% were currently working but underemployed based on our eligibility criteria. And then around 66% noted that they felt that they needed or wanted training or vocational support to help move along the employment continuum. And we asked about unmet needs at enrollment, and we can see the most commonly reported unmet need was housing, followed very closely by financial needs. And this echoes what you're going to be hearing from sites around a major motivator and driver being safe housing, followed by income. And there's also just a range of unmet needs from dental to clothing and transportation, which again highlights the need for interdisciplinary services. So our framing of the project is that it requires intentional and coordinated effort to achieve success in housing, employment, and HIV primary care, and that they're interdependent on one another. So finding and maintaining housing is difficult without employment, and finding and keeping employment is difficult without stable housing. And the lack of both housing stability and employment stability can negatively impact retention in HIV primary care. And so they must be addressed collectively for people living with HIV to achieve viral suppression. And this framing of the project leads us to the importance of working as public health social workers using a clinical, meso, and macro skills lens. So using an epidemiologically informed approach, focusing on vulnerable subpopulations and health injustice, thinking about multi-level interventions from individual to systems, thinking about cross-sectoral and interdisciplinary collaborations, and thinking about advocating for systems and environmental changes that affect health. So thinking about the person and the environment. And this is a framework from Betty Ruth around social work health impact, thinking about impact from the individual clinical intervention down to addressing social determinants of health on the population level. And this demonstration project was designed to address social determinants of health, such as socioeconomic status, housing, transportation, and access to care. But one level is not more important than the other. As we saw from Mittler's client engagement model, it's important to address client motivation as a central element. And for greatest impact, we can think about working at all levels for biggest impact. So just a few brief examples specifically from this project across sites at each level. So for client intervention, we're thinking about motivational interviewing and one-on-one work there, engagement in the process. And then prevention and health promotion. One example is an ASO bringing together employment partners and HIV testing, free hair and hygiene services, and a clothes closet to help promote health promotion and management. And then on the influencing systems in the current context level, things like streamlining referrals between agencies and interoperable EMRs. So better communication between care providers and partners means fewer barriers and better coordination for clients. And then finally, at the addressing the social determinants of health level, examples are building pathways to housing. And so that can range from expanding expand and emerge transitional housing funding and thinking of partnerships for that, or creating a housing coalition and educating private landlords about HOPWA and increasing available units and work through their concerns. So those are just a few examples that we can think about, and we're going to hear many more from Eric and Jamie and their two sites. So starting this project, different sites were at different levels along this pyramid. So the two sites we'll hear from today, Positive Impact Health Center and Kansas City Health Department, were in two different places in this model starting the program. So Eric, who you'll hear from first, is from Positive Impact Health Center. And they had a newer focus on integrating employment services and systems change. So they're going to talk about what it was like to begin this process. And then Jamie from Kansas City Health Department represents a Ryan White Part A recipient and HOPWA grantee with more systems experience and looking at just expanding that further. So with that, I'm going to pass it on to Eric to talk about Positive Impact Health Center's experience in implementing the new system approaches and the role of social workers in his project.
Hey everyone, how are y'all? I'm Eric from Positive Impact Health Centers. Just going to give you a quick overview of what we do at Positive Impact Health Centers. We are an ASO, AIDS service organization. We have 3 locations serving a 25-county geographical region, mostly centered around the Fulton County or Metro Atlanta area. We have Ryan White's A, B, and C, as well as we're a HOPWA grantee. We serve about 4,900 Ryan White clients per year and about 600 Hopple clients per year. And over the past year or two, we've increased our prep program to the point where we're now serving over 1,000 people on a yearly basis. So our intervention here with the SPINS program, we had to name it. So the name that we came up with was the HOMES intervention, with HOMES standing for Housing Opportunities, Medical and Employment Services. And on the team, along with myself as the program manager, I had 2 case managers who are both MSWs, as well as a study enrollment coordinator with a BA in psychology. And he was the person who would pretty much do like the screenings and intakes. So the main question we started asking ourselves when we began this program was, how can social workers build housing and employment service capacity in an agency and a region around Atlanta where primary focus is on healthcare and not housing? So our answer was to prove that housing is healthcare. So this is our program model, and it might be a little bit difficult to see, but on the far left-hand side there, it's kind of where we begin with recruitment. We took internal and external referrals. And then we moved to the screening and eligibility stage. That's where the individual or the patient would meet with our study enrollment coordinator. Once they made it through the study enrollment survey, they had an opportunity to consent to be in our study or to not consent to be in the study. So if they didn't consent, excuse me, we still did assist them with services and a little bit of case management. But if they did consent, they went down to the bottom part where it's more of the more intensive case management they received, kind of a one-on-one basis from the non-medical case managers. So as clients that did consent into our program, as they came into our program, this is our flow chart of how our case managers work with them. So basically, we're at the beginning there with the review client eligibility, evaluate the needs from a biopsychosocial level. Then there's the warm handoff to the case manager who collaborates with the client or the patient and starts making a plan and starts setting goals. Referrals and direct action by the case manager are based off of that collaborative interaction that they have to kind of set up like what the plan is to move forward. Number 5 there, the constant contact and support. Number 6, the follow through and follow up by both the case managers and the client. So it's constantly checking in, constantly getting back to each other and staying connected. I think one of the big differences here that we might not see in like your usual like Ryan White medical case management situation is that on our team, we had about 100 enrollees into the program, 104. So each case manager only had a caseload of 52. So that's a much more workable scenario where they can spend a lot of time being in depth with clients. They could spend a whole day with a client. They could, go with the client and do things that other case managers couldn't do, that Hopple case managers can't do. They could go to an apartment with a client. They could make, a connection, introduce clients to landlords, things like that. They could be a little more, well, I shouldn't say a little more, a lot more in depth. And that's kind of the intense case management part of it that they received in the program. So then we kind of got to the point where we're just reassessing needs every 6 months. Some folks did make it into housing within a month or 2. Some need it more than 6 months. Some it took a year, year and a half, 2 years. Just kind of depended on the individual client. The number 8 part of it is something that I think is, as case managers, it's hard to get to sometimes. And it's that, new goals for a new life, like planning, like what you're going to do after this. Now we're not stuck in that situation where we're constantly spinning our wheels. We're always, kind of in unstable housing or in and out of jobs. Now we have things stable. Like what's next? Like, how about school? Do you want to buy a car? Do you want to travel? Some of those more, higher level things that clients can succeed at. And the number 9, the clients do remain in case management throughout the longevity of the program, which Julia did mention was a total of 3 years. And then we just continued to provide ongoing case management and access to all the services within the agency. We do have a lot of different services within the agency, which I think I'm going to cover in a slide or 2. But that was a key part because not everyone's at the same spot at the same time. So when we were looking at our folks that were homeless that were coming in needing housing assistance, the real challenge is how do we keep them engaged, but at the same time, working towards their employment and housing goals, but then also, having good health outcomes. And one of the major parts, again, is just that intensive case management where the clients were referred to our program and they really have that opportunity to sit down and plan collaboratively with the case manager. And then just the referral process from there, whether or not they're being referred out for employment, for housing, if they need behavioral health services, substance abuse, pretty much whatever it is, we can kind of refer out for that. And then again, you get to that point where it's more the maintaining the housing, maintaining the employment, and just having that person to kind of lean on, to always check back in with, to kind of get advice from, to mentor, but then also that case manager just constantly encouraging you to, take the next step, do something you're afraid of, do something that you haven't done in the past because it's, because you've been unstably housed or because you haven't had the income to take care of your business. So that's kind of the continuum we looked at from being homeless to housed. And this is just a copy of a poster that we actually did. We'll be presenting it tomorrow. I wish we could have been in New Orleans presenting it tomorrow, but it'll be online tomorrow, I think at 3 o'clock. The main section there is under the 3-part plan. It's creating a plan to mitigate adherence issues and support positive health outcomes. That's just the main idea of having housing is if your housing is stable, you're more likely to come to your clinic appointments, you're more likely to take your meds, you're more likely to show up for labs, you're more likely just to be more stable in all facets of your life. So and then engaging clients and seeking their input is a major driver of success. So I think that was one of the bigger things that we really did look at. We can't be in a position where we're telling the clients what they need to do. It was really more of a thing where we were asking them, what is it that you need? What are your goals? Where do you want to be 6 months from now, a year from now? What do you want out of this? So really working collaboratively with them. And then creating and implementing a care delivery system that includes housing and employment services. Jack, can you plug this in? It's starting to die. Can you plug it in? So again, it's looking at what we're doing in our agency as far as housing and employment goes, and making sure that all the clients that are coming into our agency have access to those services, and not just the folks in our program. So it was, as Julia mentioned, taking a program that was not already at our agency and expanding it throughout our agency, so everyone kind of had the opportunity to make referrals to us regardless of what department they were coming from. So this is one of the client quote that I just wanted to include. This program really helped me out with the connection too. I got along with my case managers so well. We had a great connection, and I don't often connect with a lot of people, but I gave in there, and now I feel like I have the ability to better connect with other people. So as much as this is, I guess, a housing and employment program, it's also one of those things where, like I said, I think the clients really had an opportunity to make that connection with their case manager on a deeper level. They didn't feel like they were just kind of coming in, they were another number, another person on somebody's caseload. Having the smaller caseload really allowed our case managers to just work intensely with them. And that, again, at the end of the day, I think that says everything about the success that the clients were experiencing. So how is social work, how has the background in social work been helpful in framing and implementing our work? So from a social work perspective, we really looked at the micro, meso, and macro levels of all aspects of care that the client might need. And we were able to do that because Positive Impact in a lot of ways is a one-stop shop for services. I kind of listed them out there. We have clinics, labs, on-site providers. You can get medical case management, housing, employment, behavioral health, substance abuse, prevention, testing. We have a pharmacy on-site, which is a huge thing. And then peer consultation and community events, community outreach. So it's really one of those things where once folks come in our doors, we don't let them leave without at least offering all the services to them and kind of doing like a big picture, like what is it you need, so we can connect you to all the different departments, what you might need. Here's another client quote. It said, "I don't regret getting a case manager. I needed help. I've learned to trust people here at Positive Impact Health Centers." And key roles social workers played as part of our intervention. So the key roles for them, like I said earlier, was integrating the housing employment into the agency. We had and still have a HOPWA program within the agency, but the idea of this was to kind of leverage our HOPWA resources internally, but then externally as well, and to establish employment as a basic service offered to all clients. So, you know, as I mentioned previously, we did not have this as part of our usual kind of intake process, and now it is. So it's really been interesting to see over the last 2 years, our medical case managers, our Ryan White case managers, being able to be in the position where when they're doing their intakes, they can now offer referrals and resources for employment. When they ask, they don't just ask, "Hey, what's your yearly income so we can get your ADAP paperwork rolling?" It's one of those questions. If someone says, "Hey, I don't have a job, I'm looking for a job, can you help with a job?" Now we have those resources available. So that's something I'm actually extremely proud of having established at our agency. In creating and maintaining the referral networks, if you're going to do this, you have to have those referral networks. And that's, you know, one of those things that just doesn't, you know, poof out of nowhere. They're there. You really have to go out and scour your community and find out what is available. And one of the main things I do stress as well is when we're doing housing is that folks living with HIV don't only have to seek out housing assistance through HOPWA. Like, please send them everywhere. If somebody's homeless, they're homeless. It doesn't matter that they're HIV positive. They can receive services from any agency that provides homeless services for their demographic. If they're a single mother, you know, if it's a domestic abuse situation, if they're long-term homeless, there's so many other options than HOPWA. HOPWA is a great option, but it's not the only option. I really do stress that to our folks. And then again, the intensive case management and service coordination, being able to have a weekly case conference with all of our service providers, including clinic, behavioral health. That really is something that's come together nicely to help kind of give our clients an all-around aspect of care. We got another quote here. "When it comes to that aspect, meaning prescriptions, I had no problems. Everything was smooth, coastal clear, and I didn't really have to wait to get on meds." To me, that's a big thing to hear because a lot of our work was done with folks that were coming in as rapid entry folks, or as Julia noted earlier, a lot of folks coming out of jail or prison, you know, they get their week supply or month supply or whatever it is, but then all of a sudden, you know, they're scrambling, trying to find a place to go. Where are they going to get meds? They start getting a little bit antsy, which is, you know, understandable. So, you know, being able to come into our building and get everything in that one day taken care of, you know, to see a provider, have labs done, have your ADAP updated, to be able to walk out with meds in your hand, you know, that's just a huge thing that I think we offer our folks, and also a driver of success. So some of our lessons learned, I know I've been harping on this since the beginning here, but working collaboratively and engaging with clients. I think a lot of times as case managers, we kind of, and I know I do, you know, I've been doing this for some time working with homeless folks. It's like, "Hey man, I know best. I know what the right thing is for you." And, you know, I do have to catch myself a lot of times doing that, and remember that at the end of the day, if you're not engaging with them on a level that they need you to, then maybe you're not helping them in the way they really need. Then again, everyone is coming at this from a different point of view. They're at a different point in their life. You know, I will say most of the folks that were coming into our program were folks that needed a lot of help. They were not stably housed, without income or very low income, and having medical issues. So any steps that we took towards progress, it was a good thing. Again, utilizing the intensive case management to focus on the housing stability and to mitigate adherence issues. Create and innovate new care systems, embedding the employment services into Ryan White medical case management, and establishing clear expectations and roles for both parties, being the case manager and the client. All right, another client quote: anyone could benefit from this if they're ready. If you ask for the help, they're going to give it to you. Anyone who needs it, you've got to want it and you've got to ask for it. So a lot of that goes back to, I think, motivation within our clients, like who was really ready to take on this task. And that I will give a shout out to our study enrollment coordinator. He's a very motivational individual, let's say that. You know, he really brings it out of folks and kind of gets them, you know, he's kind of gets them amped up, gets them ready to go, gets them realizing, you can make a change in your life if that's what you want. So I'm just giving you a little bit of the preliminary outcomes so far here as of March of 2020. So at enrollment, 20% of our folks had full or part-time employment. Now 46% of them do. That doesn't include the folks that are also receiving some sort of income through SSI or SSDI. So that's a good thing. You know, that puts us in a position where, you know, a good amount of our folks have income. So that's a key building block to housing and housing stability. The next column there, the permanent housing at enrollment, zero of the 104 folks had permanent housing. As of March 2020, we're looking at 63%. That again, I think is a really nice number. It's a good testament to the quality of work that we've done to be able to take, you know, over 60% of the people and find them housing after being homeless. I think that's a huge factor. Engaged in care, we went up from 44% at enrollment to 77% as of March. I think that also, when you look at that number, that, you know, take into account again the demographic of some of the folks that were, most of the folks that we're working with, to go from unemployed, no income, no housing, and then to be able to jump that high and engaged in care. I think that's, I think it's also a testament to the work that the case managers were doing. And then the viral load suppression going from 51% at enrollment to 65% as of March 2020. Again, these are just preliminary numbers. We'll have more final data as the months go along here, and hopefully sometime in September, October, maybe sooner, that'll be, you know, we'll be able to publish that. But, you know, looking at those numbers, I'm extremely impressed with the work my team has done, but then also the fact that, you know, helping other people achieve this and realizing that, you know, if you put that effort into it to have dedicated case management, you know, look at the results you can have with some of your more difficult to work with clients. You know, these aren't the folks that are coming in that are stably working and employed and all those kind of things. So when you consider that demographic and then the outcomes, you know, everything's possible. All right, so building employment and housing partnerships. Again, I was, you know, just talking about it a little bit earlier. It's so important to go out and do this before you start a program, because you have to have those partnerships built up. Luckily, I had been working in homeless services for about 6 years before I became the program manager on this. So I had some good contacts around town, and the three folks that are on the team, the two case managers and the study enrollment coordinator, they both had excellent contacts as well. So we kind of started, you know, hit the ground running. One of the biggest thing is just educate your providers. Let them know what to expect when you're making referrals to them. You know, don't have them get sideswiped by person. You know, make sure that it's a collaborative situation. Just letting them know, you know, how our community is, and, you know, being patient, and also knowing that those folks do have backup behind the scenes. They have case managers, they have me. You know, folks have my phone number, so when things, you know, come up, you know, they do have support. The employment and housing resources are very fluid, so you have to be flexible, especially in the city of Atlanta. You never know what's coming and going, and what's available one day isn't available the next day. So, you know, you have to definitely be aware of that. Transitional housing options are vital. We really did find that there were so many times where, you know, we would get somebody connected with HOPWA, TDRA, but, you know, it's March 1st and their lease doesn't start until May 1st. Like, everything's set up, everything's ready to go. But man, what do you do with that person for those 2 months? Like, you can't let them fall back onto the street. You can't let them, end up sleeping in the woods or bouncing around. So that access to transitional housing was a huge factor. And that came in the form of hotel lodging, like extended stay hotel. But then also we use 2 websites here, that folks might benefit from. One is called padsplit.com. That's actually a startup that just started here in Atlanta. Basically like a roommate referral service. Maybe you could look at it as almost like an Airbnb situation, but a little longer term, as well as roomies.com. There's a lot of options out there where folks, if you have to get them off the street for 2 months, they can get off the street for 2 months before their TVRA kicks in. And then again, leverage all of your housing resources. Don't just seek out HIV funded specific housing. A couple more things about partnerships. With regards to employment, it wasn't our goal just to refer people out to McDonald's or to Walmart or whatever. We were really trying to get folks more in a situation where you're going into a livable wage kind of employment. So kind of shooting for the stars and seeing what happens. Definitely considering clients' transportation needs, especially folks with the long-term survivors. Actually, that goes with both. When you're addressing the livable wage and what kinds of jobs, and then also what kinds of transportation, it's your transportation situation is obviously going to be different. You have a 25-year-old versus, someone who's in their 50s or someone who's in their 60s. Or, we had one individual that he would take the bus for, I think, an hour and a half every day, and then he had a mile walk to work. So by the end of it, he was, 2.5 hours there and 2.5 hours back every night. I'm like, man, is that job worth it? Why don't we kind of look in a different direction? We ended up finding him something, that was better pay and, 5 minutes off a bus. So really looking at those kind of factors and taking that into consideration if folks don't have their own transportation. Being persistent, like, one door closes, another one opens someplace else, especially with housing and employment. You have to stay on top of it. You just do, especially from the client perspective. You can't let that one thing kind of knock you off the rails. If you go to an apartment complex and you get turned down because you have, a bad credit history, I'm like, hey man, that's one place. There's about 4,000 others we can check, that's, constantly as a case manager kind of keeping the spirits high. And then the other one here, the planning for the what ifs. What if I get sick? What if I relapse? What if I lose my transportation? There's always a solution to something, but that solution, you're not going to get that solution if you're not staying in touch with the case manager. But at the same time, the case manager, constantly staying in touch with the client and checking in and looking for updates. And just a few other things here from a local level, looking at addressing the social determinants of health. Like a lot of states, Georgia did not expand Medicaid. How much easier would things be if we would just all do that? I don't know what to say, advocacy towards that has pushed our local leaders in a direction that they're now looking at it, which is good. But that has been a barrier, I think, for a lot of states. In general, affordable housing, rent has went through the roof. Like comparatively speaking to some other big cities, like it really is at a point where I can't imagine having to go out and find an apartment nowadays because things are so expensive. Stressing livable wage, being able to stress tenants' rights and eviction protections, decriminalization of HIV laws. We actually, I think I want to say this past fall was the first time in like 20 or 30 years our state legislature is actually looking at changing some of those HIV laws that are on the books here in Georgia, which is disturbing that it's been that long, but at least we're making some kind of progress. And on the Atlanta level, just a more user-friendly coordinated entry system, making sure that you're not, giving your clients the runaround, making sure you're giving them good advice and stable foundation to start their housing and employment search. In Atlanta as well, we're looking at a a bit of a restructuring of Hopwell, you might say, is how that works on a local level. It has been difficult. It has been, throwing a monkey wrench into some of our plans, but, I think our folks have really worked through it. I'm proud of the work they've done, and, things change. So we have to be able to change with it.
Awesome. All right. Hey, everybody. My name is Jamie, and I am with the city of Kansas City, Missouri, and we're super excited to be part of this conversation. We've affectionately named our program KC Life 360, and so I want to share a little bit about that. This first slide is kind of a snapshot of who we are. We are both the Ryan White Part A recipient and a Hopwell Formula and Competitive grantee. So we're really going to operate at a very systems level and do a lot of care coordination in that manner. The Kansas City TGA is an 11 county bi-state geographical region. So we definitely have some pain points and some unique characteristics being a bi-state jurisdiction. That figure 1 is a map of our TGA. A majority of our service area is on the Missouri side. There's 7 counties there, and then 4 on the Kansas side. And that thick black line is kind of showing you where Missouri and Kansas come together. Our Ryan White Part A program, we serve around 2,700 folks annually, and that number is growing every single year. And then we serve approximately 600 folks through our Ryan White and non-Ryan White funded housing services. And this project, KC Life 360, and this effort has really been the most recent piece in a very intentional effort to expand our HIV housing program portfolio in the last 3.5 years. So before we get into the deets of KC Life 360, I want to give you that context. This is our vision. This is our philosophy, that housing is a necessary structural intervention to end the epidemic. And this is what drives all of our work. Because we are a Part A and we're really at that systems level, we have a lot of funding streams and a lot of federal regulations and a lot of project partners and subrecipients and other community agencies to sort of come into alignment with and figure out how to move forward with common purpose. So this is kind of an example of the different funding sources that we have for our housing programs. And what we've been doing, like I said, over the last few years is really getting intentional. And so what we've modeled out is this housing continuum where folks, we have homelessness to emergency shelter or maybe emergency hotel lodging, transitional housing, some sort of supportive housing with a voucher. That could be Section 8, that could be HOPWA, it could be CFC funded, you name it, and then into the affordable housing, and really recognizing this full continuum for all folks. And what the team did is what you see in green. We essentially brainstormed what were the most common or most pertinent sort of interventions or components or things to address within each phase of that continuum, so that as folks progress toward affordable housing, which is the ideal direction, knowing that you can kind of go either way, that we as a system are working through these components, whether it be in our conversations, whether it be in client housing care plans, or in securing new funds or securing new partnerships and resources. This has been kind of a driving document for our program. And you'll see employment and like credit planning and debt and all that stuff is on there. Thanks, Julia. We can go ahead. So in addition to modeling out that sort of full housing continuum, we've also really been trying to get at the nuances and really work different intersections. So that first figure you see is kind of where we were, about 4 or 5 years ago, where we had a couple of housing programs, and that's really what it was. It was pretty basic. And then the orange, we started to secure funds to get our data systems to speak. So we merged our HMIS data into our Ryan White client level database. And at the beginning of the presentation, Julia's the social work impact model, that triangle, it talked about having your systems communicate together, and that was kind of one tier of systems change. So once we kind of got our systems talking together in a more streamlined manner, our service providers could do that to the benefit of the client. And then we started looking at the intersection of living with HIV, housing instability, and intimate partner violence. And then most recently, this project is looking at the intersection of employment and earned income. So that's kind of some context about the KCHC HIV housing program. Specifically to KC Life 360, this is who we are. It involves the health department where I served as program manager, and we had a whole team. You know, we had folks who were dedicated to data and evaluation so that we can quantify, you know, why do we say housing is health? What are our health outcomes, and how do we back up that statement? We also have our employment support specialist, Ms. Debbie Adams, who's pretty awesome. And she had the caseload of clients and worked one-on-one with the clients. And then she sort of met with everybody at intake, got to know them, kind of assess where they are, triage their needs, and then she would refer them out, you know, appropriately. Our project partners included Catholic Charities of Kansas City St. Joseph. And this was an entirely new relationship for not only our HIV services program, but the Kansas City Health Department. We had never subcontracted with Catholic Charities before. However, they have a phenomenal workforce development program. And so part of our project was their manager and their employment specialist. And they had a really amazing model that we'll share later on in the presentation when you're thinking of, you know, who to partner with, or maybe how to structure an employment earned income related component to your service delivery. And then another subrecipient of this was Restart Inc., and they assisted with housing services. We had a couple of housing case managers and their supervisor, you know, lending their strengths and talents to this project. Namely, you know, Restart operates a very large emergency shelter and a handful of other programs in the community, but namely as part of this KC Life 360 model, we were expanding our transitional housing, and we'll talk a little bit more about that. Here we have a client quote. "I think this program is great. Help get me back on my feet and find residency as well as a job. 360 has really helped me out." So some of the questions, thinking about, you know, if KCHD is a local public health department, you know, how does that frame and shape how we implement our work? So again, I mentioned we were the Ryan White and HAPA, we are the Ryan White Part A and HAPA grantees. So we're really poised to push like system level change and tackle, you know, complex change. Specific to Kansas City Health Department, we're super lucky in that our director of health and the entire department really believes in health equity, looking at that in our community, advocating for it, integrating that into all of our conversations and into our daily work. Our vision for the health department also follows that public health 3.0 model. We talk a lot about social determinants of health, and you know, social determinants of health are not social needs. They're determinants, and they influence things. And I think that the people we serve deserve a system that recognizes that difference. Kansas City has also been doing a lot of work on zip code analysis. And while you can't distill a person down to their zip code, you can use that data and that information in an informed and compassionate way. And so Kansas City has done a lot related to that. And many of our clients are in our zip codes with the lowest life expectancy and many other components. And then lastly, we've been very well supported on that idea of housing equals health. You know, the health department has other housing related initiatives unrelated to HIV. And so having that leadership support from my boss's boss, and the director is also super helpful in wanting to implement a program like this. Key roles. Let's talk about social workers, some of my favorite people. So social workers, they were really the backbone of the referral network. We had a lot of medical case managers. They could be Part A funded, Part B, family case managers, so forth and so on. We also received a ton of referrals from our peer educators. Our employment support specialist at the health department, Debbie Adams, she went and did a lot of presentations to support groups and case management teams and other folks, and that really generated system level knowledge about what is KC Life 360, you know, what are the benefits, what's it all about, and how do we access that service. We also have something called service coordination meetings, which occur twice a month. And these are awesome sort of catalysts for collaboration because they bring together all of our case managers. We have folks from Part B at the state. We have peer educators. We were able to fold in all of our employment folks who were working one-on-one with clients. And that allows for case conferencing, just a ton of information exchange. And that was a great resource for us. Another huge component that social workers help drive is really integrating that, employment and earned income as being a necessary factor if we're going to talk about housing stability. That was really huge. And again, that dialogue has really been building off a lot of previous work talking about that relationship between income and stable housing. And instead of sort of jumping from emergency to emergency or crisis with individual clients, we really elevated that conversation to a systems level. And then lastly, social workers were hugely important in making those new connections. Lessons learned. This is one of my favorite slides, just so you guys know. So one of the big takeaways is that housing was the prime need and interest. And I think this is a nod back to Julia's little bar chart earlier, which she talked about across all 12 sites. This isn't just, for Kansas City. Housing was supreme need, and then followed by financial assistance. So my lesson learned that I would share with program planners and administrators is to put more into housing than you think you need or you think seems reasonable, to just go for it. Also to budget for cell phones. That was something utilized so much through this project to help keep people connected for employment opportunities and job interviews and other components as well. Kansas City also, for the first time, really got a little innovative and a little crazy and explored some alternative transportation. We had bike donations. So that was amazing because it promoted physical activity and autonomy for clients. I think folks just thought it was kind of cool as well. The bikes generated a little bit of buzz around the office, and it was exciting. And then folks could use the bikes. Maybe they took the bike to the bus route, for X amount of distance. And then, maybe they rode their bike an extra half mile or mile rather than walking to their job. So that was pretty awesome. We also utilized a lot of co-location. We pretty much did co-location every way you could imagine. We had our employment folks co-located at Restart's 22-unit master lease transitional housing property. We had Catholic Charities folks co-located at KCHD. So if Debbie was meeting with clients to talk about something, there could be a warm handoff and an immediate connection to those resources. We did co-location informally, just with office hours, and we also did some of it formally with like an MOU. So I would definitely recommend that. Also speaking to some of the same things that Positive Impact shared, client motivation and the fluidity of employment status were huge lessons learned. Again, leveraging your data system so you can track those health outcomes and you can track those program goals. And then Kansas City learned a lot about things like name change and specific barriers for trans populations, not only accessing employment, but maintaining employment. Here's another quote. "I'm so happy, I just did not think I would ever get a place that was all mine. That was not my car. I have my own key that I do not have to share with anyone." This client stands out to me. The kind of the thing about this individual is they were in their car a lot or maybe having to do couch surfing. And the most meaningful thing about accessing housing was that moment when they had their key and they're like, I don't have to wait in my car. I don't have to sit on the front porch. I don't have to wait for someone to get home or give me a ride here, do this or that. They just had the ability to go home when they wanted to, when they needed to, and their home really became their space. And here's another quote. "We are stable, safe, and together we are in a good spot." This is a single mother of 3 who actually was fleeing domestic violence from out of state and came to our program. And she worked with Debbie and was able to secure employment. She ended up finding a safe space for her and her children. And she really worked through a lot of kind of different challenges or barriers or kind of decision points came along her way. And she really navigated them very well. And we're really glad to have gotten to work with her, and we're proud of her. So here's some data. Again, preliminary aggregate information. But these numbers, to me, they just sing off the slide because, when we think of this population, as Julia and Eric shared, folks, had no income or very low income, no housing, poorly engaged in care. And so to make these kind of jumps from 14 to 40% for full or part-time employment, it's amazing. This project taught me how much the community is like desiring of employment opportunities, you know, and that included getting your GED. We had clients go to do CNA. We had a client become a traveling nurse. You know, there's a whole spectrum of potential, and so it's just sort of meeting that need and helping connect the resources for folks. Also super proud of increasing permanent housing. And then I think also viral load suppression and engagement in care. I think those are pretty significant jumps. So I just want to talk a little bit more about that Catholic Charities model. I would encourage anybody to consider implementing something similar. So every Monday they would have Job Club, and on Tuesday, workforce development. Wednesday, they could do a little more kind of one-on-one resume workshop style, you know, make computers available, et cetera. And then on Thursday, they would hold mock interviews. They could also do computer skill classes and then one-on-one training. So this isn't to say that at any time a client couldn't schedule, you know, a specific one-to-one with someone. That was always available. But what was really cool about this model is it really addressed sort of all folks at all stages of employment readiness and motivation. So someone could go on Monday and honestly by Friday, like have a job. That happened multiple times. If someone wanted to maybe do Monday one week, Tuesday the next week, Wednesday after that, it could really be at the client's pace, but this was a supremely successful model. Drivers of success. Voc Rehab was fantastic. A lot of our community colleges, again, we had a lot of students pursue that route. We had a young man who was a manager at a Domino's doing pretty good, but decided, you know, I want to go back to school and I want to be a teacher. And so we're working with that person to kind of support those career goals. And a cute little phrase that was really helpful, our employment support specialist would say is like the ABCs of employment: a job, then a better job, and then a career, and really work with clients through thinking through that for themselves. Kansas City Cold Storage and the Full Employment Council were also great drivers of success. From our housing partnerships, again, we leveraged what we already had in place. So that would have been our HOPWA folks and some of our COC funded folks. But namely, we expanded our transitional housing kind of in two ways. One, Restart purchased a master lease 22 unit building. So, you know, from the jump, as folks did intake there, they could meet with the employment support specialist. And as they talked about their housing goals and stability, if employment or getting a job was part of that conversation, there was a warm handoff and kind of an immediate connection to the KC Life 360 program. And we also found some other kind of more miscellaneous folks like our housing choice voucher people and our DV providers. Hotel gap lodging is a huge landmark success for this project. We learned a lot from our friends at Positive Impact Health Centers and another one of the SPINS funded sites. And this was our first time ever doing that. And so I would encourage anybody to ensure you have through a funding source emergency hotel voucher stays. This was key for us. We served 17 people with this pot of money, and now we formally folded it into our HOPWA award. So that kind of sustainability is totally possible. We've also improved integration in our COC coordinated entry. You know, we've been working, getting folks into coordinated entry has not been a problem, but like the appropriate full level of advocacy and people like really understanding our population has been a challenge, and we've made some great strides there. And then we've also done some things with our housing authority, doing some MOUs to kind of get a side channel of permanent housing, which then frees up things like our traditional HOPWA TBRA. So this slide is probably something you all feel as well in terms of like how do you advocate and where is change needed at the systems level. And I know it's kind of redundant from what Positive Impact shared, but again, advocating for affordable housing, what is a livable wage, looking at eviction prevention and legal aid and representation in eviction court for tenants, and then how we articulate, you know, housing as health through our data, through our outcomes, and with intentionality. And then again, we've done a lot of advocacy with that holistic assessment for all of those continuum of care funded housing assistance programs.
So thank you so much to Jamie and Eric. I know that was a lot of information, and we just have a quick slide on what's next. So sites are looking into sustainability and making sure that the interventions and partnerships continue after the demonstration project ends. Completing the evaluation so we have more data and a fuller and final picture of the outcomes that we're just preliminarily sharing here. And then in the coming year and looking at implementation manuals, so all sites are developing kind of a step-by-step recipe for implementation with logic models, flowcharts, forms used by the agency so that other sites can look at that and kind of implement what works for them and put it into their agency for replication. So that will be available on Target HIV when that's finalized. So now we just want to say thank you so much for listening. We know it's been a long day in front of your screen, so we'd love to hear your questions, answer your questions, and any reflections that you might have. I know there's been questions in the comment box that our moderator is going to help us address, and we'd love to help unmute people who'd like to speak as well.
Thank you so much, Jamie, Eric, and Julia. So we'll just go ahead and get started with the questions in the chat box. And if anyone, after we go through the questions through the chat box, if anyone would like to unmute themselves and ask a question, you'll be free to do so. So the first question is your needs assessment shareable? And that might have been when Julia was speaking.
I think it might have been when Eric was speaking. So I think that might be in referring to your like biopsychosocial assessment, how you look at like all elements of the client.
I would be willing to share anything. So whatever somebody wants, you know, I think there's going to be a slide with our contact info. There you go. Feel free, honestly, just that's my personal cell. I don't know if that was a good idea, but that's my email. So honestly, whatever you guys want, just send me a request and I'll find it for you to put you in the right direction.
The next question is, what type of challenges do you see as people start to return to jobs post-COVID? How do you think that will impact our clients that have already struggled in that viable, struggled to find viable jobs?
I think that nobody knows anything right now. So when is it going to be? You know, is your state going to be a partial open? Is it going to be a large opening? Like what's going to happen? You know, I think if I had that answer, maybe I should be doing work someplace in the current administration. But I mean, I think at some point it's just going to be a flood. Like eventually things are going to open back up and things are going to start happening again. And I think it just depends on, you know, where you're located, where your metro area is, or what kind of region you're in as to like what kind of jobs are going to be back. But I think a lot of the, you know, the service industry stuff is going to go away, but there might be, you know, other opportunities for other things. Who knows what's going to happen?
Yeah, and we've had clients like express, you know, originally like before maybe they were interested in like working at Amazon or a grocery store or something like that, but just expressing like a lot of fear and anxiety and putting themselves in that situation. And so just kind of abstaining from, you know, looking for those jobs or taking those job opportunities that are available right now.
Okay. The next question was, can we get a copy of the presentation? And I provided an answer for that. So someone has a question about gap lodging. What is that exactly?
That was from Beth. That's a really good question. So what we consider gap lodging or hotel lodging, like basically what we did was we, like Jamie said, her plan does too, is we have an MOU set up with a local hotel provider. It's called In Town Suites. You know, you might want to check them out. If they're located in your state, they'd probably be willing to do the same thing with you. And basically what they do is they give us a little bit of a discount on the weekly room rates. And that the reason being is that we send quite a bit of business their way. In between our Hoplo program and this program, we probably had anywhere between, I'd say maybe 80 to 120 people a week in hotels across the region. So that's part of the HOPWA funding is the gap lodging.
Thank you. I know in Houston, we're using that gap lodging to provide immediate housing for people who are coming out of prison or jail.
Yeah, I mean, it's beyond valuable if, and I stress, if you have the case management resources to manage that. Because like I said, on my team, you know, each case manager has 50 people, but for a HOPWA, you know, on a HOPWA team, like those folks might have 60 people just on TBRA alone with, you know, all the other, you know, gap lodging, STROM-U, PHP. So it's, you know, you're putting somebody in a hotel, you know, you definitely got to watch like where you're putting them in, and that's where the whole biopsychosocial comes in. You know, if you know somebody has a history of meth use, probably, you know, you're going to want to pick carefully which hotel you put them in based on the area. So
yeah, and I would add that, you know, HOPWA caps that kind of assistance at 60 days, but this is a different funding stream. This is SPINS, and that 60-day cap didn't exist. So administratively, this was really wonderful. On average, everybody stayed 57 days in Kansas City on average, but we did have somebody in there for 114 days. So, you know, that's not a service we could provide in that full length of time with HOPWA. So I would say that was an added benefit of doing gap lodging through this funding source.
And it's another way, I was speaking earlier in my presentation, is leveraging what resources you have. So if, you know, a client came in and they were in HOPWA gap lodging, as Jamie said, for 60 days, then, you know, if they were in our program, we could then take over paying for that hotel for another 60 days so they can kind of transition into their place. And, you know, heck, we've had people that had stayed there for, you know, 5-6 months at a time, but it's because that was the option, you know, based on who they were, whether they were, you know, elderly or, you know, very compromised with their health. Like, you know, our option wasn't, you know, scoot back to the street, whereas Jamie said HOPWA caps it at 60 days. So it's kind of like, hey man, you got 60 days to do this. If you don't, you know, they ask you to leave the hotel. Whereas we, you know, we're a little more generous with how long we would let people stay.
Thank you. Are the intense case managers and medical case managers two separate roles within your organization, or does the case manager serve both roles?
They can both do the same things, but they don't both always do the same things. So when I say medical case managers, I'm really referring more towards the Ryan White folks, where they're, you know, they're doing clinic intakes, they're doing ADAP, they're, you know, kind of hustling them in to get them in to see a provider. Whereas the intensive case managers were more like for patients that were, you'd say maybe out of care, because that was the main focus of this, that folks had bad health outcomes, were missing appointments. So those intensive case managers, you know, would work with those folks that were kind of like, you know, we're plucking the ones that were, you know, really needing like that extra level of help. So, you know, long story short, they both, if you listed out all the tasks that they can do and that they do work on, they're all kind of interchangeable, but they don't always do it the same way. I don't know if that makes sense.
Yeah, and in Kansas City, you know, all of our clients had a Ryan White medical case manager that was doing, you know, their 6-month updates and their labs and their doctor appointments and their ADAP and their, you know, mental health, substance use referrals, or et cetera, et cetera. And then our employment support specialist was really there to pay particular attention to that, like that conversation and that discussion, and refer for those resources and support the client in that realm. And it was really kind of like a care team approach. They were like very different roles, just to provide that like very specific support for whatever that person's kind of employment goals were, et cetera.
So we got a couple of questions from one person. How does your organization work with clients that are unable to stay employed? What methods have you used to work with those clients? And what barriers do you find keep your clients from staying employed?
It kind of goes back to my slide on like resources, just constantly, you know, collecting those resources to provide opportunities to clients. Like, yeah, we had some folks that got a job and just, you know, knocked it out of the park, and now they're a manager at the place they're working for. We have some folks that have had 6 jobs in the past, 6 months. It's tough. It's kind of tough to say, who's going to go in what direction. But I think, again, with the intensive case management, the better you prepare them, because you kind of walk them through those interview skills, the life skills. Again, like I said, the what ifs, like, what if I get turned down for this? What if if I can't give them a clean drug test, so, well, maybe we need to get you to an employer that doesn't drug test, so just, again, looking at all of those factors and kind of putting it together a plan that works for that one person.
Yeah, I think common reasons people didn't maintain employment were things like they didn't feel good, so they they didn't call their employer to call in sick, and some of it is really just teaching, like, hey, call in sick, because if you just don't show up, then they just, like, so many people just assumed they were fired, and like the times are like, I don't work there, I'm fired, and just kind of walking them through that. Or, like, they work at a location, they're like, it's just too far away, so they quit going, or they didn't call in, and it's like, have you asked your manager if you could transfer to a different location? Like building in, like, those kind of decision trees and walking them through that process. And then we had some clients, we had one client who was a trans woman who kept getting jobs, had this phenomenal skill set. How she would present an interview versus how she would present day of employment, day 1 and on, was different. And she actually lost jobs. And so we worked with legal aid to get her name changed and some components like that. And that just sort of seemed to shift the conversation.
And two, like, again, the whole life spectrum, where folks are, long-term survivors. One of the good resources that is a key component to this program, and maybe if somebody could, maybe Julia, if you could pop that, the link for the back to work training sessions. It's through HUD. It's an excellent thing. It's, it's kind of short. It's just 3 videos about folks with HIV getting back to work and kind of what that looks like, how you build it up within your agency, where to go for it. There's a lot of options, but that's a really good training. It's available and it's free for all case managers or anyone that wants to do it.
Okay, so we have about a few minutes left, and we have a lot of good questions in the chat box. I do want to allow people to unmute themselves if they have any direct questions they may want to ask to you all that may be in the chat box, or other questions. So I know Gillian maybe, Blackman.
I have a question, but I'm not Blackman.
Okay, go ahead, Mr. Williams.
Yes, Eric, thank you. Jamie, thank you. You guys did a wonderful job. I'm here in Houston. And so my question, Eric, you were talking about employers, potential employers for your clients. And my question was, and I think I know the answer to it, but does the employer know the health status of your client?
I get it. Yeah, I saw your question there. That's a good question, because it's really tough to hide that because when we go to meet with the employers, we tell them who we are, what we do. They can easily look it up online and figure out, hey, if I'm getting a referral from Positive Impact Health Centers, they can make, the inference. So it's tough to kind of, to work around that if somebody has, kind of an issue with that disclosure and everything. It's really case by case basis. We do tell clients, like, just be aware, that folks do know, the employer is going to know, that your fellow employees don't have to know, but the chances are that your employer is probably going to know this. So if you're uncomfortable with it, tell us now, or if things come up, we got your back. But it's kind of hard to hide that fact,
Right. Well, we don't do it at our agency, but this is some of the issues that we have. I have an employer, and I'm constantly sending clients over, and these clients are out sick, or they have doctor's appointments, and then now the employer wants to know what's up. So that puts me in a bad position. That's the reason why I asked that question. Right. How do you deal with that? I know you can't disclose certain information, that being one of it. So I just was wondering how you got around it.
We actually worked like with Catholic Charities to, they knew more about like, hey, what are the common questions that come up in a workforce arena that you do not have to answer, and like how do you respond, and giving examples and practicing those conversations with people, whether it be like post-employment or in an interview setting. So we really just kind of leaned on them to kind of navigate, what's the kind of stuff that comes up, and then how do you respond to that.
Okay.
All right.
Well, Eric, I'm gonna definitely be getting in contact with you with your information.
Yeah, do, please. And Julia, could you tell Anthony, maybe the group, what is the site in Houston? Or
Is it Avenue 360?
Yeah.
I was gonna ask you that. Are they a part of this program?
Yep.
Okay, I will definitely be getting in touch with them.
Avenue 360 and AFH are partnered together as a site.
Great. Is anybody in particular I should be calling?
If you want to email me, the email Julia on the contact slide, I can do a warm handoff connection.
I appreciate that. Now, how do I get in touch with you?
Yes, I will put it in the chat box, and it's also available on the slides on the webpage for the conference.
Thank you.
Right. It is 4:16, so we're 1 minute over. And I would just like to encourage everyone to download the slides from the conference website through the agenda portal, and you can get all the presenters' contact information, the presentation, and also do the evaluation for this session, so that these presenters can get some good feedback on their presentation and the work that they're doing. I would like to thank Julia, Jamie, Eric, for your session and presenting on the population that you are working with in your respective areas. I would like to encourage everyone to attend the preliminary session tomorrow morning at 9:30. They have been outstanding. If you have not been able to join those, so I would like to encourage everyone to join those. At this time, we are done with this session. Thank you so much. I know it's been a long day. It's happy hour time somewhere. And just go and relax and reboot for tomorrow. Thank you so much.
Thanks all.
Anthony.